and good morning everyone. Myself Dr. Shobhit Mathur. I am an assistant professor of Cvts at UNMICRC Institute of Cardiology and Research Center, and today, in continuing the CC program by our institute, I'll be speaking about mechanical complications of MI. Specifically, I'll be covering the left ventricular aneurysm. So let's start with the presentation. I'll be covering my presentation under the following heads, starting with the definition, which is very important. Then briefly we'll look into the history, pathology, clinical features, the various imagings and investigations that we do, and then covering the natural history of the disease, and finally coming to the surgical principles and techniques, covering the results of the surgery and making a nutshell slide just to summarize whatever we have discussed. Before starting, I want to state that I am not owning any of the materials that I am going to show in this presentation. The entire thing has been taken from the standard textbook of cardiac surgery, Kirkland textbook, and some images have been taken from the internet from various sources. Now, starting with the definition. So, what is an aneurysm? We all know, but what is an LV aneurysm? Specifically, in this presentation, we will be discussing about post-infarction LV aneurysms. The aneurysms that develop after an attack of MI, post-infarctional, they are well delineated transmural fibrous scars. Please remember that every word is important here. Post-infarction, well delineated means well demarcated, transmural, that is full thickness, and it's a fibrous scar. What is a fibrous scar? It is totally devoid of muscle tissue. Fine trabecular pattern is replaced by smooth fibrous tissue. In systole, the movement of this portion of the LV wall is either akinetic, that it doesn't move at all, or it is dyskinetic, that means it is showing paradoxical movement. I'm also putting up a diagram here, image that is taken from the internet. This is the LV aneurysm. You can see it is located at the apex. You can very well see that the apex is dilated, the LV wall is dilated. Compare the thickness of the normal musculature of the wall and the aneurysmal wall. It is thinned out. There is no muscular pattern here. So this is what an LV aneurysm is. Post-infarction, it develops after MI, well delineated, well demarcated, totally devoid of muscle tissue. And on doing a 2D echo, we will be able to see the akinetic or dyskinetic movement of this aneurysm, which we'll see further. Scars and infarcts, they are not aneurysms. Why? Because they are not discrete. LV wall is not thin and it is interspersed with muscle tissue. So, more or less the definition of aneurysm is morphological till what we have discussed. Johnson and colleagues, they came up with a easier and better understandable physiological and echocardiographic definition of aneurysm that says a large single area of infarction scar that causes the LV ejection fraction to be profoundly depressed to 35% or lower. A large single area of infarction or scar that causes the EF to go low, below 35%. Scars and infarcts are not aneurysm. This is one thing to remember from this slide. John Hunter was the first person who recognized an LV aneurysm. In 1880s, people had started establishing a relationship between stenotic CADs, myocardial fibrosis, and LV aneurysms. But in 1967, Corlin and colleagues, they reported a strong suspicion of aneurysm based on history, physical examination, and echocardiographic findings. 1944, the surgical treatment began. Beck reinforced fascia lata, the transverse fascia lata, to reduce the expansile pulsation and chances of rupture. 1955, closed ventriculoplasty with a special side-lighting LV clamp was performed by Lykoff and Bailey. They reported 5 survivors among the 6 patients they operated. In 1959, Cooley and colleagues in Houston, this was a milestone year, that in this year they reported the first successful open excision of aneurysm using CPB. Now coming to pathology, if we have understood the definition of the aneurysm, then understanding the pathology is very easy. Here in this image, you can see, I have placed an image of true aneurysm and also an image of pseudoaneurysm. So a true aneurysm or a mature aneurysm is basically a white fibrous scar. It is visible externally and from the endocardial surface. Wall is thinned out. The endocardial surface is smooth and non-trabeculated. We have already discussed that it is totally devoid of any muscle tissue, and the demarcation is very clear from the normal LV wall. More than half of the aneurysms will have a mural thrombus attached to them. Sometimes this thrombus may get organized, it can get calcified, and pericardium over the surface is densely adherent. That means the pericardium has got dense adhesions which cannot be surgically, sometimes it is very difficult to do the lysis of these adhesions surgically. A pseudoaneurysm, on the other hand, will have a rupture in the LV wall due to infarct, and it will have a pericardium covering over it. So it is basically, pseudoaneurysm is made of non-myocardial tissue and aneurysm is made of myocardial tissue. Again, the thing to remember is well demarcated, thinned out, totally devoid of muscle tissue, and containing a mural thrombus with pericardial adhesions. So it forms a spectrum from a classic LV aneurysm to diffuse, scattered, sparse, punctate scars that we see while performing CEVGs. Why this happens? This happens because during MI or after MI, the myocardial necrosis that sets in is rarely homogeneous. Why it is not homogeneous, we'll see subsequently, because of the collaterals. Coming to microscopy, just a brief thing. An aneurysm is a hyalinized fibrous tissue with a very small number of viable muscle cells present. Fibrous tissue will take at least 1 month to form. So, to call any infarct or any dilatation of the LV wall an aneurysm, pathologically we will have to wait for at least 1 month. Collagen will start laying within 10 days. So, in the first week after MI, what is there is that there is wall thinning, there is dilatation, the muscles, they start getting necrotic, but it is not a true or a mature aneurysm. Mature aneurysm will take at least 1 month to form. 85% of the aneurysms are located anterolaterally near the apex. That is the classical LAD territory. Few are on the lateral surface, that is the OM territory, and only 5 to 10% are on the posterior surface, that is the base of heart. So the thing to remember is that 85% of the aneurysms will be apical. Most common location of an aneurysm will be apical. The posterior or inferior aneurysms, half are false aneurysms, but the apical aneurysms mostly or nearly all are true aneurysms. The true posterior wall infarction or aneurysm, basically if a aneurysm sets up in the posterior wall, then definitely there is some damage to the commissural tissue of the mitral valve. So there is high prevalence of post-infarction MR or mitral regurgitation. What is the concept what is the prospect of CAD in a case of LV aneurysm? Most common cause of an LV aneurysm is a multi-system CAD. Yes, I agree that they are on the LAD territory, but the disease mostly are multisystemic, involving more than one system. Single system LAD CAD is seen only in less than half of the cases of classical aneurysms. What happens to the left ventricle? The left ventricle will have an increase in cardiac volume and weight. Why? Increase in volume will be due to thinning and bulging of aneurysm. Obviously, if the wall is thinned out due to there's a concept called Laplace law, which says that the wall stress is directly proportional to the ventricular diameter, the ventricular pressure, and it is inversely proportional to the thickness of the myocardium. So the thickness of the myocardium decreases in a case of aneurysm, and hence the increase in volume happens. Aneurysm will get thinned out and it will bulge out. The non-aneurysmal or the normal portion of the LV wall, due to secondary hemodynamic stress of the aneurysmal segment, will undergo remodeling, and that will again lead to an increase in volume. More than 20% of the LV wall, akinase or dyskinesia is required to cause LV enlargement. Larger the akinetic area, the greater the enlargement of rest of the ventricle. What is the time course it takes is not clearly defined. So the thing to understand is that in a case of LV aneurysm, there will be increase in volume of both the aneurysms due to the aneurysmal dilatation and the dilatation of the normal LV. Aneurysms are morphological diagnosis as per the definition and only at the operation on autopsy. Froelich and colleagues, they found no aneurysms in 3 of the 18 patients they operated for aneurysms. Small to moderate sized aneurysms have got no specific symptoms, only angina due to CAD. So what are the clinical features of aneurysms? The most common is severe angina, severe disabling angina. 31% of the patients will present with severe disabling angina. Then there is a spectrum of heart failure alone, or heart failure symptoms with severe angina. That will be approximately 40%. Third commonest symptom, and one of a very important symptom, is the presentation is with ventricular tachycardias that can be fatal and life-threatening. Then minor symptoms are heart failure, mild angina alone, and mild effort dyspnea. So the thing to remember is that the most common symptom is angina, heart failure, and ventricular tachycardias. Dyspnea will set in at the time of infarction. Heart failure requiring medication. 15 to 30% will have VT. Sometimes intractable VT can lead to death. Half of the aneurysms, they contain a thrombus, but embolism only happens in a minority. The reason being the thrombus mostly gets organized and it may get calcified also, so it doesn't embolize. On examination, we will have a diffuse sustained apical systolic thrust, double impulse, S3 and S4 gallop rhythms, and if an MR is present, then apical pansystolic murmur of MR will be there. Imaging starts with an X-ray that can show an increase in the cardiac size. Left ventriculography has emerged as a very sensitive tool for diagnosing an aneurysm. Other than that, yes, a routine echo or a transesophageal echo is required. Advanced imaging can be a radionuclide imaging, cardiac CT and MRI can be done. Incorrect diagnosis, they do happen in a case of aneurysm. Sometimes we'll have to go for a cath study if right heart failure is also suspected to evaluate for PA pressures, and a coronary angiography is a must because the cause is MI. Here we can see in this echo, this is an echo image showing the LV aneurysm, the bulging of the LV wall, and the neck of the aneurysm can be seen. This is the normal LV cavity and this is the aneurysm. Again, yeah, same thing, the normal LV cavity and the aneurysm. Just a word about ventriculography. Ventriculography, basically what it shows is that there is a bulging of the aneurysmal segment. Okay, we can see a thrombus in the aneurysm segment and lack of inner trabeculations. Here we can see the normal LV wall, there's got trabeculations. Here we can see some trabeculations, but here in the case of aneurysm, there is only a thrombus here and no trabeculations. So the endocardial surface is seen as a smooth surface. So this is how you can diagnose an aneurysm on these imaging studies. Here I am putting a cardiac CT that shows an aneurysm with a neck. Historically, 10 to 30% of MI survivors, they developed LV aneurysm. The incidence has decreased drastically. I mean, for the benefit of the human race, it has decreased drastically because of the good thrombolytic therapies and percutaneous coronary interventions that can be done in emergencies that have actually decreased the prevalence of a permanently occluded LAD, as most of the aneurysms are seen in the apical region. So if we open up the LAD after an attack of MI, then the chance of aneurysm they decrease. The prerequisite for an aneurysm formation is that it should be a large transmural infarct and there should be very few intracoronary collaterals. If the collaterals are there, then definitely the survival of muscle tissue will be there and aneurysm formation will be less. So if we open up and after thrombolysis, what will happen is that the LED will open up, and more than that, sometimes the collaterals also open up. So necrosis sets in very late and chances of aneurysm formation are less. This was well supported in the studies by Foreman and colleagues. Normal or supranormal systolic function in adjacent ventricular segments leads to higher chances of aneurysm formation. Why? Again, we will have to go to the Laplace law. High interventricular pressure and wall tension in the infarcted area can lead to an aneurysm. Mechanism for increasing symptomatology is basically gradual increase in size of akinesia or dyskinetic segment, gradual reduction in stroke volume and global ejection fraction that happens with the continuous remodeling of the heart. It is aggravated by myocardial ischemia developing in the non-aneurysmal portion. That means if the patient develops second MI, then the symptomatology due to the aneurysm caused by the initial MI will definitely be more. LV after an aneurysm will show changed curvature and thickness, global performance will be decreased, cardiac remodeling and generalized dilatation. Due to paradoxical movement, what happens is the most of the systolic work is wasted on the expansion of the aneurysm, and this is basically the cause of the heart failure. Early systole, aneurysm and border zone, they bulge outwards, paradoxical movement. What happens to the RV is that the functions may be impaired due to akinesia and dyskinesia of the septum. The LED is also the vessel that supplies the septum through its septals. So if the septum gets thin or the function of the septum deteriorates, then definitely the RV function will also start deteriorating. Secondly, due to MR, we can have increased pulmonary artery pressures, occlusive disease of RCA in a multisystem CAD can be there. So basically, both the LV and RV functions, they start deteriorating. Survival. Akinetic area that are not true aneurysms, if untreated, the survival is 69%. Dyskinetic areas, which are probably aneurysms, the 5-year survival is reduced to 36%. Dyskinesias, they do worse rather than akinesias because they are associated with a low global LV ejection fraction. Size of the aneurysm is a risk factor for premature death. And for very small aneurysms that are without heart failure, the survival is basically dictated by the coronary artery disease that the patient has. What is the severity of the CAD? The function of rest of the ventricle, the normal myocardium, how much it is able to perform and how much remodeling happens is the major determinant of the survival. So if we have a large aneurysm but the function of rest of the LV is preserved, so the survival is better. Coming to, obviously we are surgeons, so we have to discuss the surgical principles. Now coming to the surgical principles, the surgery that can be planned for such a patient is resection of the post-infarction LV aneurysm with CABG. And one of the very important thing to remember that I said in definition also, that the pericardial adhesions, if they are dense, if the pericardium is densely adherent to the LV wall, it is not to be lysed. It is optional whether you go for a vein graft or a lima. If lima has to be grafted, then it has to be harvested first. Moderately hypothermic CPB, some surgeons they prefer double venous cannulation, some go for a single venous cannulation. Vent classically is not to be placed, but again it's a preference. If required, it can be an RSPB vent can be placed. Aorta has to be clamped. Definitely for giving cardioplegia, we have to clamp the aorta. And only after clamping the aorta, the dissection of the pericardial adhesions has to be done. This is a very important thing because while handling the aneurysmal portion of the LV, the thrombus might break down, and that can lead to dislodging and embolic events. So if a thrombus is there or pericardial adhesions is there, then it is always advised not to do pericardial adhesionolysis before giving plegia or before clamping the aorta. Once you have clamped the aorta, plegia is given and the heart is arrested, then only do all these maneuvers to do pericardial additional lysis. And obviously in such a case we have to anticipate a very long surgery, so warm induction cardioplegia can be used. If the pericardium is densely adherent to the aneurysmal portion, then there is no need to do any additional lysis. It is better to excise the aneurysmal part of the LV along with pericardium. Loose thrombus, if we find a thrombus, it has to be removed. But before removing the thrombus, we have to be very sure that it doesn't dislodge, and so it's always better to keep a sponge over the aortic and mitral valve. So even if the small emboli that are getting dislodged, they will not be thrown into the systemic circulation. Incision that we'll see in further. What is the incision? Basically, whatever incision we take over the aneurysmal wall, we have to leave a thin rim of scar tissue, because scar tissue is a fibrous tissue, so enough strength is there to take the sutures. Endocardial tissue around the aneurysm, if any excess endocardial tissue is there, it has to be removed, because this is basically the cause of intractable VTs. So, as we already discussed that most of the aneurysms are apical aneurysms. So the first technique for repair of such aneurysm is a classical technique or a linear closure. This is basically a intra-op schematic diagram. Sorry, this is not working. So the cannulation has been done, and we can very well see that the aneurysm has been located. So the incision has to be taken. Now where to take the incision? Incision has to be parallel to the IV groove and the thinnest portion of aneurysm. Why? Because it causes least distortion of the LV wall. Here in the inset diagram we can see that where the incision has been taken, so that the excision of scar is also there. Some rim of scar tissue is left for closure, and there is least distortion of the remaining LV cavity. A PTFE felt has to be used. In fact, two felts have to be used. In the classical technique, what we are doing is just simply excising the aneurysm and then doing a closure. Closure, we'll have to take stay sutures at each end, that can be silk stay sutures. A PTFE felt, two felts have to be placed on both the sides. Now classically in this technique, number one silk or polyester suture is used. Horizontal or parallel mattress sutures are taken immediately adjacent to each other. In the inset diagram we can see that how the sutures are taken. The sutures, the septal suture has to be taken a bit deep to exclude the septal scar. And after taking all the sutures, once we start tying the sutures, so before tying the last suture, some bagging can be done by the anesthetist to de-air the left heart. So here in this diagram we can see that after closure how it will look like. The aneurysm has been excised, the suture line is there, the incision has been closed using PTFE felts at both sides, and after taking the horizontal mattress, a reinforcement suture has to be taken. That is basically a Prolene suture number 0 or number 1, superficial to the mattress suture. This is very important, that the bites for reinforcement sutures have to be taken superficial to the original mattress sutures to cause a complete watertight closure. One must always try to avoid the incorporation of distal AD in the sutures. So after this classical technique, what was described was a patch closure of the LV defect, described by the two great surgeons. Dorr described it as endoventricular circular patchplasty, and Cooley termed it as endoaneurysmography. The rationale is that basically, along with the aneurysm, scarring is there, akinesia is there, dyskinesia is there in the septum. So patch excludes septal scarring from the reconstructed LV. This is the rationale for using patch, that while using a patch, what we can do is that the septal tissue, akinesia, dyskinesia and scarring can be excluded from the reconstructed LV. It improves the LV function and maintains the curvature of the LV wall. Now what happens in this technique is, Fontaine and colleagues, they did a lot of work on this subject, and they studied basically the dimensions of a lot of normal hearts and according to the age, and the dimensions of the various aneurysms that normally get formed. So they have devised a measurement for the patch that we are going to take. Fontaine said that the patch should be a classical oval patch. The diameter of the patch should be 2 to 2.5 centimeter. The actual diameter has to be 0.5 centimeter more, that is 2.5 to 3 centimeters. So this half a centimeter thing is given basically to compensate for the suture, for the space taken by the sutures. If we use a larger patch, then we'll have more end-diastolic volume in the LV and less ejection fraction. If we use a smaller patch, then less LV volume will be there and less compliance will be there. So patch has to be sized appropriately. A better approach, or what we can do additional to sizing the patch, is that a pre-shaped balloon, 50 to 60 ml size filled up balloon, can be inserted into the open LV cavity for chamber sizing and shape. Now, once the patch has been sized, then a 2-0 Prolene suture is used to basically take a purse string along the line of demarcation between scar and myocardium on septum and free wall. So we can see here clearly that a purse string Prolene suture is taken. After taking the suture, the longitudinal and transverse diameter of the defects are measured, and the patch is basically that is used is a composite patch. It is made up of polyester, that is Dacron, polyester or Dacron, sorry, and pericardium on one side. So this composite patch can then be sutured to the defect. We have already discussed that the size of the patch has to be 0.5 centimeter greater than dimension. It has to be a gelatin oblique collagen impregnated polyester or a polyester backed by pericardium patch. So the patch was taken with, so the purse string was taken with a 2-0 running Prolene suture, and the patch gets sutured by 3-0 Prolene or 3-0 polypropylene. Both are incorporated into each other, and finally it will look like this, what is shown in the diagram. The suture line has to be watertight to avoid any false aneurysm, and before tying the final knot, one must try to dear the left heart by doing some backing. So after the patch has been placed, the remnant of the scar of the LV wall can be closed with a 2-0 running Prolene suture. So in this diagram we can clearly see that on the LV wall a circular patch has been taken, and over it a reinforcing closure of the remnant tissue has been done using 2-0 running Prolene sutures. Sometimes we might encounter LV aneurysms that have a very small LV cavity. So in such cases, direct reconstruction with multiple purse string sutures is described and no patch is to be used. If an associated mitral regurgitation is there, then there are two approaches. Either we can repair the mitral valve or we can do a replacement. So a repair has to be done from the LA approach, or an LV approach can also be used. The classical technique described for repair is the Alfieri stitch, that is stitching A2 and P2 together. In the diagram we can clearly see that the Alfieri stitch has been taken that leaves two mitral valve orifices. or if a replacement has to be done, then the replacement has to be done through LV. How it has to be done through LV? We can see that from the same incision in the LV, the thinnest portion of scar parallel to IV groove, the incision that we took for the aneurysm repair. So the same incision, all chordae are divided at the tips of papillary muscles. So after division of the chordae, the leaflets are to be excised, and small rim of AML tissue is left adjacent to the aortic cusp to avoid damage to the aortic cusp. So after excising the valve tissue, we have to basically size the valve, and after sizing we have to remove the holder of the valve. After removal of the holder, what we have to do is we have to invert the valve and hold it by hemostats. This diagram clearly shows that the holder has been removed and the valve has been held by the hemostat by the assistant, and the sutures are to be taken in such a fashion that the pledgets are to be kept on the atrial side. The routine MVR surgery where the pledgets are on the atrial side, that the valve gets inserted from the LV side, so the holder has to be removed and the valve has to be inverted. Again, LA is DA'd by a rubber catheter. That is a normal procedure that we do, placing a Foley's through the valve. So, post-op care. Post-op care is basically similar to all the other surgeries, intracardiac operations. Yes, RV and LV dysfunction will be there, so we can expect a prolonged post-op management. So, management, a PA catheter, if it is there, it will be helpful in the post-op. IBPs, inotropes, fluid management, antibiotics, control of sepsis, and routine ICU protocols have to be followed. Looking at the results of the surgery, the early or the in-hospital mortality in such cases is 5 to 7%. The 30-day survival is 90%, and a 5-year survival is 65%. Till date, we have got only one randomized controlled trial, that is the STITCH trial, surgical treatment of ischemic heart failure trial, that randomized CABG and CABG with ventricular reconstruction into groups, and the 5-year survival in this trial was 67%. This is the only trial for the, only randomized controlled trial for aneurysm surgery till date. Most common mode of early death is acute CHF. Late death can be due to chronic CHF or a second MI causing an acute heart failure, and sudden death can be due to intractable VTs. Survival gets affected by incomplete revascularization. That means if the bypass grafting, the CABG has not been done and undergrafting has been done, so we must always try to do maximum number of grafts that are feasible, and we should avoid undergrafting. The scar removal has been incomplete. Sometimes there are formations of new scar at the suture lines, and definitely if the age of the patient is high, then that thing adversely affects the survival, and life-threatening ventricular tachycardias can cause sudden deaths. Coming to the symptomatic results of the surgery, the survivors are mostly in NYHA class 1 and 2. The symptomatology has been reported better for the patch closure, and the poor performance of LV is mostly due to the sometimes very small aneurysm that even after resection, the functional improvement of the LV is not much, and if the damage to the non-aneurysmal portion has occurred, and incomplete resection. Froelich et al., they did a study and they found out that only 50% of the ventriculography assessed area was resected in most of the surgical endeavors. The exercise tolerance and the exercise performance of the patient increases. The paradoxical movement on echocardiography they decrease, and decrease in LV and diastolic pressure and volume will lead to decreased wall stress. So to achieve these results, we have to be very specific about our patient selection, that symptomatic large aneurysms with angina and heart failure, they are the ideal candidate for surgery. Symptomatic large aneurysms, very small aneurysms, even if we resect and do resection and LV wall reconstruction, then the symptomatology after the surgery doesn't improve much. So, symptomatic large aneurysms with angina and with heart failure, they are the ideal candidates for surgery, and the surgery has to be CABG and patch closure. We must try to avoid the patients that are in advanced NYHA grades of high failure and with two system disease and chronically failed patients, because they are ideal candidates for transplants. LV scars encountered during routine CABGs may be excised and a surgery can be done of wall reconstruction if they are of large sizes. So in a nutshell, I can understand that that this PPT has been mostly descriptive. So firstly, what is important is that we must understand the definition of aneurysms: discrete fibrous divide of trabeculum showing akinesia and dyskinesia. Minimum 1 month time has to be there to call it an aneurysm. Scars are not aneurysms. Most common location is anterolateral near the apex, and most common symptom is severe angina alone. The surgery in these cases is ventricular reconstruction with CABG, classical or linear closure without patch, and Dor and Cooley procedure with patch. The post-op death is mostly due to CHF. Thanking you, and with this I would like to end my presentation.